Good evening, all. I welcome you all to the 93rd webinar of Believers Church Medical College Hospital. Today, the webinar is by the Department of Optical. Our HOD will be talking to you on getting ready to face the impending pandemic pandemic myopia. Dr. Satish Thomas did MBBS from Kottayam Medical College and MD Ophthalmology from AIIMS, New Delhi. He did his fellowship in pediatric ophthalmology and strabismus from Shankar Netralaya, Chennai, and Westmead Children's Hospital, Sydney. He was on the faculty of CMC Ludhiana for past 14 years. Currently, he serves as the professor and HOD at the Department of Ophthalmology in Believers Church Medical College. He'll be talking to us about a pandemic myopia. Over to you, sir.
Good evening, everyone, and thank you, Leena, for that words of introduction. So the topic we'll be looking at is what can we do about this impending problem that confronts us, myopia, which is approaching epidemic proportions across the world. The magnitude of the problem is that currently the prevalence of myopia is about 22.9% worldwide, of which 2.7% are high myopes. But by 2050, it is expected that 50% of the world's population would be myopes, and of which 10% would be high myopes. In certain parts of the world, mainly Southeast Asia, Singapore, Taiwan, Hong Kong, those countries, Korea, the incidence of myopia is much higher, affecting about 80 to 90% of young adults there. In India, thankfully, the prevalence is lower than in Southeast Asia. There are not too many studies. The few studies that we have across the last 4 decades show that the prevalence is 7.5%, but even within those studies, there is definitely an increasing trend. And the other difference is that earlier, while this was a problem confined to the urban population, right now that urban-rural divide is being lost, and the rural population is affected almost to the same extent as the urban. The risk factors for myopia and myopia progression are genetic, of course, but more than purely genetics, it is a gene-environment interaction. Parental myopia is definitely a risk factor for both the development and the progression of myopia. If one parent is a myope, then the child has a twofold risk of getting myopia. If both parents are myopic, then the risk increases threefold. Younger the age of onset of myopia, higher the rate of progression. In gender, generally studies show that there is a female preponderance, but it could be due to environmental factors related to girls being more indoors as compared to the boys. And when the Jewish population is studied, the Jewish boys have a higher prevalence as compared to the girls, because culturally they are involved more in study of scriptures, and therefore it is probably an environmental factor that comes into play in gender. Ethnicity, we've already said, the Southeast Asian population has the highest prevalence of myopia. And even when they migrate to the Western countries, this prevalence continues. Probably it needs a longer time before that risk subsides. The European population has a lower prevalence as compared to the Southeast Asian race. Baseline refractive error, the lower the baseline refractive error, the lower the rate of progression. The higher the refractive error to start off with, you will find that the rate of progression is higher. So these are all factors that we need to keep in consideration when we are looking at how can we slow the progression of myopia. The visual environment definitely plays a role. And this is there when we look at all the other risk factors, because irrespective of whether genes play a role, gender plays a role, ethnicity plays a role, we find the environmental factors, visual environmental factors playing a role, in the sense that longer the near activity, the higher chance for myopia development and progression. Similarly, lesser the outdoor activity, higher the risk. And similarly, lesser the sunlight exposure and more the subject is confined indoors, higher the risk. So this is believed to be probably even the reason why certain ethnic groups are more affected, probably because the Southeast Asian population and the Chinese race are found to be more academically and driven than some of the other races, even in the Western population. So probably that's why they show a higher risk. Anyway, visual environment has been definitely proven to be one of the most important risk factors for myopia. Accommodation anomalies, an accommodation lag or an esophoria or high AC by A ratio, these are all found to be independent risk factors for the myopia. So what are the options that we have to control myopia, the rate of progression of myopia? Definitely, because these environmental factors play a role, that is something that should be paid most attention to. Increasing the outdoor activities to balance out the increased indoor activities that have now become a part of life. Sunlight exposure. So compared to earlier generations of human beings, the present generation has so much less sunlight exposure, and this is believed to be very much responsible for the increase of myopia. Increased near work is again something that should be addressed, and unfortunately the COVID pandemic has really played havoc with this, so much so that even whatever little outdoor activity or non-screen work we had earlier, everything got converted to near work and screen work. Work, play, everything became at a particular distance. So these factors being looked into is one of the most important measures that we can adopt for myopia control. Some of the other interventions we will look at in more detail. The first is undercorrection of myopia on spectacles or contact lenses. Can that be a measure we can adopt to reduce myopia progression? The mechanism by which this is believed to control myopia is that undercorrection reduces the accommodative effort and reduces accommodative lag. So the accommodative lag, what it does is it focuses the light behind the retina and therefore acts as a stimulus for myopia progression. It is accommodation that gives a myopic shift, and if the child does not accommodate, then the light focuses behind the retina. So accommodation is what brings the point of focus from behind the retina to the retina. So if there is an accommodative lag, then that can act as a stimulus for the axial length to grow so that the light gets focused on the retina. So that's the mechanism by which undercorrection might actually help. Unfortunately, the randomized control studies showed that there is no effect of undercorrection of myopia. In fact, some studies even show that it actually increases myopia progression. So the current recommendation is to give full correction of myopia so that vision is improved and it does nothing to progression. Bifocal or progressive addition spectacles are another intervention that is tried for control of myopia. Here the mechanism is again that it reduces the accommodative effort. RCTs have shown that it does reduce progression, but it is not really clinically significant. One very important study by Cheng showed that executive bifocals with basin prisms did reduce progression by 51% over 3 years. So this study shows promise. And currently, the recommendation is that these progressive addition spectacles are most useful in myopes with esophorias and accommodation lag. So this is the subgroup of myopes where this intervention shows most benefit. Another recent treatment modality is what is called DIMS, defocus incorporated multiple segment spectacles. So on spectacles, we have this dual focus spectacle lens. There is a central optical zone which is 9 millimeters, and this corrects the distance refractive error and brings the light rays to focus on the macula. Around it, there is an annular multiple focal zone with multiple segments of plus 3.5 diopters, and each segment is 1.03 millimeters in diameter. The mechanism is that while the center comes to focus on the macula, in the periphery, there would be a myopic defocus so that the stimulus that we saw earlier for the axial length to increase is taken away. In fact, the stimulus is in the other direction. So the mechanism is that these DIMS thus reduce the accommodation lag during extended near work by inducing relative myopic shifts in the peripheral refractive error. The same thing can be done in contact lenses, bifocal or multifocal contact lenses. So here is a diagrammatic representation that explains what I just said. So normally we know that in myopia, light rays come to focus in front of the retina. And axial myopia is the best way to understand it. So you already have a larger eye, and so light rays come in focus in front of the retina. So when a contact lens is used for correction of myopia, a single vision contact lens, what it does is it brings the point of focus from in front of the retina to on the retina in the center, in the macula. But what happens is in the periphery, it is focused behind the retina. Now, this can be a cue or a stimulus for increase in axial length. So what these multifocal contact lenses do is that while focusing the center on the macula, the peripheral light rays are brought to a focus in front of the retina, signaling the eye to slow the growth of the eye. So this is the mechanism by which the multifocal contact lenses are believed to reduce myopia progression. Soft bifocal contact lenses work in the same way, except that it is not a multifocal, it is bifocal. So there's a central distance design with the reading portion outside the central contact lens, and this creates a myopic defocus in the periphery. The RCTs have also found this to be effective. Then you have the rigid gas permeable contact lenses. These act by a different mechanism. They act by flattening the cornea mechanically and reducing the myopia. So once you flatten the cornea, then the light rays come to focus on the retina. The corneal curvature, however, changes only temporarily And when you take the contact lens off for some period of time, the cornea regains its original shape. RCTs have shown that these RGP lenses slow progression, but doesn't reduce eye growth. Then we have what are called the orthokeratology contact lenses. Now, these are lenses, special type of lenses that are worn during the night hours when the subject sleeps. And during the waking hours, the next day, the subject is off contact lenses or spectacles. Every night it is worn, and during the day, there is no refractive correction. So these lenses act by flattening the central cornea and corrects the central refractive error while leaving the peripheral myopic blur, which acts as a cue to slow the progression. And they have been found to slow progression by 50% and slow the axial length growth. So here's the diagrammatic representation. This would be the shape of the cornea before the orthokeratology lens is worn. And then at night, while sleeping, on or before sleeping, the lens is fitted. So this lens, what it does is, it flattens the central cornea, leaving the peripheral cornea as it is. So that this it does mechanically. Next day, even with the lens off, the central cornea is flattened and the peripheral cornea remains as it is. So we have the light rays in the center focusing on the retina, and in the periphery, we have the myopic defocus. So the same mechanism by which the multifocal or the DIMS works, it is the same mechanism here in orthokeratology. Finally, we have low-dose atropine, which is a pharmacological measure to control progression of myopia. This is believed to reduce myopia progression by reducing the axial length growth. Different concentrations are available, of which 0.01% is what is commercially available and is approved by the CDSCO. And however, this should be prescribed with caution or by adding bifocals in myopes who have an accommodation lag. So let us see where atropine stands in the control of myopia, because this is the easiest modality to adopt, and therefore it is more likely to be accepted and used. So we have to be quite well versed with it, where it stands correct. So I will be spending most of my presentation on atropine. So the first study to be large-scale study to be done on atropine for the treatment of myopia was the ATOM-1 study, which did it with 1% atropine. And it was found to be effective. So mechanism here with 1% atropine is that it paralyzes the accommodation and helps in the control of myopia. The problem with 1% atropine was that it blurs vision and photophobia and all those side effects of atropine. So it really isn't a viable option. It might help in reducing progression of myopia, but it doesn't help in everyday life. So therefore, lower concentrations of atropine were tried, and there was the ATOM-2 study, which was a 5-year clinical trial. In it, 400 ethnically Chinese children were studied with these concentrations of atropine. They were divided into different groups. 0.01, 0.1, and 0.5% atropine were given to the different groups for a period of 2 years. This was the phase 1 of the study. And then in phase 2 of the study, it was a washout period where the drugs were stopped and they were followed up for a year while not on atropine eye drops. And then there was a phase 3 study where these patients were continued to be followed up. And if myopia progressed by 0.5 diopters or more, then they were restarted on 0.01%. Even if they were on the higher concentrations of atropine earlier, all of them were started on 0.01% for another 2 years. This was the phase 3 of the study. And these were the results of ATOM-2 study, which was that 0.01% atropine is more effective than 0.1% and 0.5% in controlling progression of myopia. There were fewer side effects for 0.01% as compared to the others. Axial length, however, showed no difference at the beginning of phase 3, either with each other or with the control group. Now that was the slightly surprising part or the disturbing part of the study, because it is believed that atropine would act by reducing the axial length. However, at the end of 5 years, at the end of phase 3, there was a slightly smaller axial length progression in 0.01 group as compared to the other groups and controls. So these ATOM-1 and ATOM-2 studies were done in the ethnically Chinese patients. Could we translate these findings to the other races, to the other ethnic races? That was the question. And so we had the Indian ATOM study, the I-ATOM study, which was a multicentric randomized clinical trial in India, done by these 3 centers, the RP Center at AIIMS, Shankar Nethralaya in Chennai, and Narayana Nethralaya in Bangalore. So the inclusion criteria for the study subjects was that 100 children aged between 6 to 16 years with myopia of 0.5 to 6 diopters. They should have had myopia progression greater than 0.5 diopters during the preceding year. Astigmatism should have been less than 1.5 diopters, and anisometropia should have been less than 1 diopter. And the results of the I-ATOM study was that the treatment arm, that is 0.01% atropine group, did better than controls in this spherical equivalent at the end of the study. So axial and even the axial length progression was slower in the treatment group, but it did not reach statistically significant levels. So though myopia was controlled, whether it was definitely due to control of axial length was the question. So this is where atropine stands now. Mechanism is that it does slow the progression of myopia, but whether it is due to axial length elongation being controlled is still open to study. The other possible mechanism is that it could be because of changes in the crystalline lens curvature secondary to the reduced tonic accommodation, but the concentration is really low, 0.01%. The other thing about atropine, using atropine, is that the reversal is high for higher doses. Once atropine is stopped, myopia progression can continue. But this is higher for the higher doses. With the lower doses like 0.01%, the rate of rebound is lesser. The 5-year clinical trial showed that axial length progression did reduce in the 0.01 group, as we saw in the ATOM-2 study. And so the probable mechanism that is proposed is that there are receptors in the retina or sclera that inhibit the thinning and stretching of tissue. And so the 0.01% atropine probably acts not by a mechanism related to accommodation, but related to some receptors here preventing axial length progression. The higher doses are more effective than lower doses in preventing myopia progression, but it has more side effects. Rebound is also progression for higher doses, and these are the lower doses for atropine. So where do we stand right now? ATOM study did show that it is effective in East Asian children. I-ATOM study showed that probably the effect can be translated to the other races also, but there are still several questions. that remain about atropine for the control of myopia. The questions that remain is, what exactly is the mechanism of action by which atropine works? We are not sure as things stand. Is it by accommodation, by reducing accommodation? Is it by reducing axial length growth? We are not really sure. There are studies that show a little bit of effect this way and that way. We still don't know what is the ideal duration of treatment that we need to give atropine. When can we stop atropine treatment and still the effect of that continues? Or when we stop, is there a reversal? Then we've lost everything. When to start, when to stop, all this, the research is still going on. What is the ideal dosage of atropine? So these are all questions that are not yet fully answered at this point in time. And so before I move away from atropine, let me give my caution or hesitation in fully embracing atropine at this point in time. The evidence base of atropine that we have right now is not really robust. There is promise. There's definitely promise that it could be one of the answers to the control of myopia, but we are not yet fully there. So we need to exercise caution. Why I am more concerned about atropine as compared to the other modalities of intervention that I spoke about, like say, for example, dim spectacles or multifocal contact lenses, is that those are less likely to be abused as compared to atropine. Atropine is easy to prescribe. You just prescribe it, so much so that right now there are even patients, children coming to our OP who have been prescribed these atropine eye drops from optical shops outside. You have myopia, here is a drug to control it. Now that is very dangerous at this point in time. The reason for that is that it is, so more than the evidence based approach, my hesitation against atropine at this point in time is related to the philosophy of medicine. Irrespective of which worldview or philosophy of life that we hold, most of us would believe that our human body is created in a particular way, structurally and functionally, to function in a particular way optimally. And certain diseases can cause it to function in a non-optimal way. And therefore, our intervention must be directed in such a way that to correct what has gone wrong in the physiology and the anatomy that is optimal. In other words, there is a good way by which the human body functions, and pathology is what has gone wrong with that. And our treatment modalities must be to redirect the pathology back to the original good physiology. If so, then the biggest hesitation I have with atropine is we don't exactly know in what way atropine is correcting what has gone wrong. Until we know the exact mechanism by which it is acting, I would exercise caution in prescribing it universally. The dictum that I would follow is, if something isn't broken, don't fix it. Or the corollary to that is, fix what is broken. So in myopia, from all the risk factors that we saw, what is definitely broken is a wrong lifestyle. Eyes are not meant to always be focused at a near distance. It should be balanced with relaxation of eyes for far distance and for peripheral vision. Instead, when our lifestyle has changed from that to always a near distance, then our eyes are continuously in accommodation. It is not relaxing. It is not using peripheral vision. So this is an abnormal way of usage of the eye. So that is what should be given priority in what we need to fix. The other interventions, when we know that it corrects what is broken, then let us embrace it wholeheartedly. So finally, this is my last slide. The recommendations that we have now to control myopia, which is definitely approaching epidemic proportions worldwide. As we know, all this, if when we project it now, the statistics show that by 2050, more than half of the world's population would be myope. So does it mean, therefore, that we have to target all the myopes that are there? No. When to initiate therapy? Only when we have documented evidence for progression. Is there progression that is happening on documentation? And this is the least progression that we need to address. That is, there should at least be half a diopter of progression per year. If not, it is really not worth targeting, because we must understand that progression of myopia is physiological in a growing phase of life, because already, as we saw, in an axial length that is larger than normal, light rays would focus in front of the retina. And when the eye grows, obviously myopia would progress. If we are going to initiate therapy in any of these children, we have to do a good workup before we start them. So anterior segment, posterior segment evaluation, good dilated examination, all that goes without saying. But a cycloplegic retinoscopy is mandatory to evaluate the refractive error, to know how much myopia is there. Because unless you do a cycloplegic retinoscopy, you will not know exactly how much the myopia is. Because accommodation induces myopia. So unless you relax the myopia, unless you relax the eye, you will not know exact myopia. So this is mandatory. And axial length also needs to be documented before initiating therapy. And on follow-up, you need a meticulous follow-up. All of this must be documented, and it is good to document it on a myopia growth curve or chart. So unless these things are being meticulously done, we should not be prescribing any intervention methods to any of our children in the growing phase of life, apart from the environmental measures. The environmental measures should be recommended and implemented along with all other interventions if we are employing any other interventions. And if we are not, we should be definitely emphasizing this point. So this is where I think all our role should come. We should be educating society in these environmental measures. We should be going to schools and telling the teachers and the school authorities how important it is that the children balance outdoor activities with indoor activities, restrict screen time to less than 1 hour per day. Now that appears almost an impossibility now, isn't it? But that is the recommendation. So finally, the aim in our intervention of myopia is only to slow progression and not to stop it completely, because progression of myopia could even be physiological to a certain extent during the growth phase of life. So thank you for patient hearing. If there are any questions, then I can take that.
Thank you, sir. Thank you for that informative talk. Do we have any doubts? So as we know, we have so many children coming to us with myopia. Like you said, it's turned into a pandemic. We have so many parents who are very worried. They come to us telling that the power is increasing, what to do. So what would your advice be to such worried parents, sir?
Yeah. So my first advice to them would be that you can't do much about the the fact that they are already myopic. So as we saw, there are several factors that led them to become myopic. The parents invariably, most parents invariably come and say it is because their child was on the phone for a long time, and they think that is what has caused the myopia. It may or may not be. And most often the parents who tell me that would have spectacles on their own face. So even while they know that this might be the cause, still they are not doing anything much about it. So my main focus would be to tell them that there is a healthy way of use of the eyes, and that has to be emphasized. The unhealthy usage of the eyes has to be avoided as much as possible. So that is, I'll just re-emphasize those points. Our eyes are not meant, are meant to be primarily used to see the world at large. We have, a huge field of vision. We have binocular vision. So all these are not meant to be only at a small distance to look at a target which is 25 or 30 centimeters away. So most activities should be for that. And it was like that if you just go to 2 generations before for humankind. And it is only in the last, say, 2 or 3 generations that human beings have shifted their use of eyes to this way, which is definitely pathological. The other thing is that earlier generations used to spend more time outdoors. So in outdoors, again, obviously the distant vision is being used, peripheral vision is being used, binocular vision is being used to a much greater extent, plus there is sunlight exposure. And vitamin D also has been shown in some studies to play a role here. So what we should be telling parents is, please balance your child's indoor activities with outdoor activities. Second thing, some of the phrases I use is, let the child's work now is at a particular distance. When the child has to study, it has to be near work. Therefore, please don't make the child's play at near work. Let the child's play be at distant work. So the child's play must not be on gadgets. If so, then work and play, everything comes at 25 centimeters. So that shouldn't be. Send the child out to play at least 2 hours per day. And this is something that we should even be telling schools, that schools should have mandatory outdoor time built into their curriculum. Physical PT classes and all that. Now, I don't know, everything got shifted because of this. Then there is this 20-20-20 rule that primarily came from the computer vision syndrome. So computer vision syndrome, we know, was because of the reduced blinking rate that the computer professionals had. So that would cause tiredness of eyes. So we used to say that every 20 minutes, take your eyes off the screen for 20 seconds and look at an object 20 feet away outside the window to relax the accommodation. The same thing we should be telling these children for, who have no option but to do screen use for a certain period of time. So these are some of the things that we can tell them. And that is far more important than these other intervention methods that we do. The intervention methods can be an add-on in certain cases.
So when do you review your children with myopia? Every 6 months?
Yes. Every 6 months normally should be good enough. The advice that I tell them is you have to follow up every 6 months if there is no complaint. If the child has no complaint about vision, then 6 months mandatory follow-up. But before that, if the child complains that vision has dropped, child is not able to see clearly, come back before that.
So you would advise a change in spectacles only if a power difference of around 0.5 is there?
Change of spectacles probably related to the visual acuity also and things like that. But yeah, all these interventions for myopia, that is where the cutoff says that there has to be a 0.5. That is how progression is defined. So any intervention to arrest progression of myopia, you should think of including them into that intervention only if myopia progression is there, and progression is defined as greater than 0.5 per year.
Okay, sir. Sir, one more thing about the dual focus spectacle. Who do you think would be the ideal age group for that? Because for younger children, we might have to keep changing the spectacles. So is there any ideal age group or?
There is no real ideal age group apart from the fact that these spectacles are very expensive and they are difficult to get. So right now in India, I think it has just come and there is only one company that manufactures it and imports it. So availability is a huge problem and the cost is the other big problem. So, and then as you said, the problem with cost is it's not a one-time buy, because the power keeps changing. So it needs, so that much cost has to be spent every 6 months or so. So those are the problems. So apart from atropine, all the other treatments modalities have their own problems. Contact lenses, the other dangers, in a child, the problem of contact lenses, infections, aberrations, all those problems. With spectacles, the most effective spectacles probably the high cost. Therefore, the higher the chance that atropine will be abused, and that is my fear.
Yes, sir. Thank you, sir, for that wonderful discussion. Do anyone else have any doubts?
Yeah, so probably I will just end with, let us do our best in educating our society in the.
Excuse me, sir, we have a doubt in one of the chat box. I'll just read it out to you. As an opinion from the community, it was said that if we see greenery in the morning, it would help decrease myopia for children or prevent myopia. Does the green nature have an effect or is it just the effect of the outdoor time?
Yeah, I'm not sure how to answer that scientifically, because unless study proves that, we probably cannot substantiate that statement. But it does make sense to my mind, because much of the world that God has made is green and blue, the blue sky and the green in the rest of the world. Therefore, probably green and blue colors would have an effect on the health of the eye. And less of that by being indoors and not exposed to those colors might also have a role. So apart from the distant vision, maybe the color also, but it's a good topic to do a study.
Yes, sir.
Just another query. Could it also be, see, when we do the refraction and we look at the colors, so if they have a predominance on visual acuity of seeing red more, we say that they are myopic. So could that also be in line with the question that was asked in the chat box, that the greens would probably be the non-myopes and the reds would be the myopes?
Yeah, I don't know. Yeah, I think that the red-green thing would be more to do with the where the light is focusing in the retina. Yeah, probably. We can. Interesting questions, interesting food for thought. So, especially the youngsters in the audience, you can think of doing, randomized control studies on these topics.
Any more doubts? So I think we can wind up this session. Thank you so much, Satish sir, for your valuable time, for giving us this great talk. I would also like to thank all the participants, all those who took their time to come and listen to our webinar. Thank you so much. So see you again for the next webinar.